Insights from the world's best medical minds. You are watching TheRightDoctors.com.
Namaskar. At the onset, I would like to thank RightDoctors.com and Right Doctors for sharing, disseminating knowledge across the world on different areas of medicine. I am Dr. Shashank Joshi. I am the Dean of Indian College of Physicians, and I am today going to talk the most hot topic, which is managing COVID from Mumbai, which is the epicenter of the pandemic from India. We all know that this coronavirus SARS-CoV-2 came from nowhere. It looks like an ordinary RNA virus, like a flu virus with a mortality rate less than 1%. But one clear thing, as the pandemic panned out in the last 3 months in Mumbai, Maharashtra and rest of India, we clearly saw that this virus is predictably unpredictable. The mortality rates are high, and we have a VVIP population, which is the vulnerable population. And we developed a COVID score that any person from India who is above 55 years of age, who has hypertension, who has diabetes, who has chronic heart disease, chronic lung disease, chronic kidney disease, chronic liver disease, any immunosuppressed state, or any severe disease can be vulnerable to COVID and its complications and mortality. Pregnancy and children below 10 are special vulnerable groups. So those are the groups which were the hotspots. Now, predominantly the testing revolves around the symptoms, and COVID symptom triology was typically shortness of breath, fever, and dry cough. But suddenly we realized that simple fatigue or diarrhea, severe pain in the calves, backache could be unusual symptoms. And typically we saw anosmia or lack of smell, change of taste, particularly preservation of bitter and sour taste, were also some unusual symptoms apart from diarrhea. So clearly the current strategy is symptomatic testing and asymptomatic carriers or contacts to be traced aggressively. So that is the current strategy. How do we test or diagnose COVID? It's a clinical diagnosis confirmed by an RT-PCR swab from the nose or the throat, which is usually false negative 30% of the time, and the timing is critical between the 5th and the 10th day. However, ideally we should do a viral load of it because we know how much is the viremia, just like we do for retrovirus diseases like HIV or hepatitis. We need to know the viral load. Now, typically if that is negative and we still suspect SARI, which is severe acute respiratory illness, then we do an HRCT, which is sensitive 85% of the times. And that has been often used in SARI cases, which we see. Now, typically, most people who are pre-symptomatic, asymptomatic, 80-85% of people will recover if they are not in the vulnerable population. And we started using simple tools like having a pulse oximeter, and if you have unusual tachycardia, as well as exertional tachycardia, exertional fever, or a saturation after a 6-minute walk test. If you walk for 6 minutes and you have a desaturation below 3%, if you do it twice a day, or if your saturation drops below 92%, then you need to rush to a hospital. In mild disease, most people typically had some treatment options which were used. So what were the treatment options? Typically, most treatments are experimental. We don't have good randomized control trials, and most drugs are repurposed drugs. That means they were indicated for something else and we are using them for something else. So one of those experimental combinations, which is awaiting validation, is a typical trial of hydroxychloroquine with azithromycin with a little bit of zinc, 5 days, 400 milligram twice a day for 5 days, azithromycin 500 milligram daily for 5 days with 50 milligram BID of zinc, vitamin C 500 milligram twice a day, vitamin D 60,000 units, one daily for 3 days. That was a standard of care protocol. However, we need to generate more and more RCTs. We have to do adaptive trials and cement this. So an alternative protocol which came from Bangladesh and now being validated, it's under research trials, is doxycycline 100 milligram twice a day for 5 days, ivermectin 12 milligram daily for 3 to 5 days is also being under research trials with some reasonable results which are coming up. Then of course now we have an antiviral agent called favipiravir, which is 9 tablets in the morning and evening of 200 milligrams on day 1, followed by 4 tablets twice a day of 200 milligrams for 13 days. But that also needs validation. We need more RCTs. We need to generate a lot of evidence. And that's all for mild disease. Most mild disease, we need to be very, very particular between days 6, 7, 8, and between 8 to 12, that they don't develop something called as a cytokine storm, in which they desaturate. And often you need to do HRCT scan, and we need to be very mindful and careful of these population. So obviously, when person progresses to moderate COVID or severe COVID or critical COVID, then we have our antennas focused on three areas. We have an antiviral agent called remdesivir, which is again a off-label indication. We need to generate more and more RCTs. The current RCT on remdesivir is improving recovery time in moderate to severe cases. Usually it is given as 200 milligram first day, and then 4 days of 100 milligram, usually given IV. But you have to be very cautious because it can cause abnormal liver enzymes, and you have to do hepatovigilance. Just like we need to do cardiovigilance for HCQS or hydroxychloroquine, we need to do liver vigilance with remdesivir. But that is virus for a virus. But it is not the virus. For the first 9 to 10 days, the virus is very replicative. But after 9 days, it is the immune inflammation which takes over. And the immunology and the inflammation of COVID really takes over very aggressively. And then it is the thromboinflammatory disease which is predominant, where you get a cytokine storm, you can get myocarditis, you can get a myocardial infarction, you can get a stroke, you can get even unusual hyperglycemia as COVID pancreatitis and COVID hyperglycemia. So how do you treat that? For anti-inflammatory drugs, often we have a lot of experimental options. Sometimes the role of IV methylprednisolone 20 milligram BID for 3 days, which is the Henry Ford Michigan protocol, has been used. That's an adaptive trial. It's not a typical RCT. And if somebody is ventilated, so only for mechanically ventilated patients, we are using something called as a dexamethasone 6 milligrams, and that was from the recovery trial. But typically, treatment of COVID is not medications. It is supportive. It is oxygen, and it is high flow nasal oxygen and non-invasive ventilation, which is the key, with awake prone positioning. So if you are prone and if you give a lot of oxygen with high flow, and sometimes people need up to 15 liters of oxygen, that is the key. And still, if people desaturate, one has to intubate and give mechanical ventilation. So steroids have a role. And when the cytokine storm sets in, sometimes we use IL-6 blockers. These are basically cytokine modulators. So we have tocilizumab, which is used IV, and we also have, that was basically a drug for rheumatoid arthritis, and we have a drug for psoriatic arthritis called itolizumab. Again, both are drugs which are repurposed drugs, and they are undergoing trials across the world for outcomes which we need to see, but they can clear the cytokine storm. And if all this fails, we still have a novel option. We take donations from the blood of the plasma which comes out from people with COVID who have recovered. Now we know that we have the antibody tests which are available. Basically, there are two types of antibody tests. The IgM, which starts kicking in after the 7th day, usually goes out after 14 or 21 days. And then we have the IgG test coming up from the 8th or 10th day, which goes up to 28 days. So usually if you get plasma from patients who have high titers of IgG antibodies and donate that plasma to sick people as an off-label use, this is undergoing a lot of research trial. In fact, in Maharashtra, we are doing one of the largest trials called the Plasmid trial for plasma. And of course, the safety of this was documented by the Mayo Clinic trial, but we need to document efficacy of this trial. And that's another experimental option which is available for COVID patients. But remember, what is key is when they did autopsies of COVID patients, they saw a lot of thromboembolic phenomena across the world. And therefore, what is another important tenet is never forget antiplatelet agents, never forget statins, and most importantly, never forget heparin. Whether it is heparin drip or low molecular heparin, that is also a key in management of COVID cases. So it's all supportive care with a lot of heparin as per the D-dimer and various biomarkers which are available. And as I told you, most COVID patients will recover. It's important that we don't lose focus on their nutrition. We give them adequate vitamin D, we give them adequate vitamin C, we give them some vitamin D, as well as some zinc. All of them are immune adjuvants. Ensuring that they get the right proteins are important. In fact, we have also shown by research that coconut oil is very important, MCTs are very important, and many of these immunity boosters, whether they are from the regular nutritional stable or they are from our traditional Ayurvedic stable, whether it's ashwagandha, whether it's tulsi and so many other things. They're all immune nutrition. They're all immune supportive medications. They can aid recovery or keep the immunity intact. So as you understand that the virus attack is the initial attack, but it is the immunoinflammation thrombosis which is really causing the disastrous consequences of mortality. And in order to save that, all you need to do is do a oximetry walk test. Even at discharge, we actually do a walk test with oximetry. And if person passes that test, then we send the patients home. Some of them who have high D dimers, we send them on a low molecular heparin home because we need to follow them up closely. Now, a lot has been talked about the vaccines. Now, remember, a couple of vaccines are protective. One of the reasons India has got less mortality of COVID, less COVID, is because we are BCG vaccinated. So there is a lot of role, and our Association of Physicians of India, and I'm author of those guidelines, has come out with immunization protocols of regular vaccines should not be stopped during the COVID times. We know BCG is protective. We know oral polio might have been protective. We know MMR may be protective. All these have protective abilities, but they are all in research mode. We need to do proper randomized control trials in these situations. Are there other novel and new drugs which are being experimented? Yes. There are novel drugs like montelukast, which can prevent cytokine storm. There are novel inhaled steroids like cyclosinide. All of them are being tried in research form. And there's a novel gout drug called colchicine. All these are experimental drugs. And mind you, all the previous drugs which I alluded to also are experimental, because currently, except supportive care, oxygen, and dexamethasone, nothing really has robust database and RCT evidence to support mortality outcomes. At the end of the day, a lot has been talked about vaccines. And we have two such vaccines which are coming out. One is, of course, from Bharat Biotech with the ICMR, and that is a live attenuated vaccine. Another one is a DNA vaccine coming from the Zydus Cadila. Both these vaccines have promise, and there are a lot of Indian manufacturers which are coming with the vaccines. But that will take a little while. Maybe in 2 to 3 months, under robust clinical trials, we will have a vaccine for COVID first. But remember, COVID is a predictably unpredicted virus. So what is crucial for COVID prevention? COVID prevention, what is crucial is SMS with umbrella, because we are in monsoons in Mumbai. It's heavy rains now. So SMS, S stands for soap or sanitizer. M stands for a proper masking, preferably N95 mask, at least in healthcare situations. And the third S stands for social distancing. So if you maintain physical distancing, and if you can't maintain physical distancing, ensuring that properly covered mask is very, very crucial in COVID prevention. If both the people across wear mask appropriately, correctly, which does not slip down, your chance of getting COVID are less than 0.5%. And then, of course, all the fomites from where COVID can spread, we should adopt a no-touch technique. No touching is something which is a part of our Indian traditional culture. And if you follow the no-touch technique, like Namaste, ensuring that we don't touch the doorknobs, the touch points, which are called as high touch points, which are like the switches and so on and so forth, and mobile phones, which is a vector, that is something which is important to recognize, and we can prevent COVID. The last point which I want to make is try to have 2 hours of digital detox every day, because there is so much of sensory overload. There's so much of information coming from everywhere that try to do digital detox. Try to eat on time, try to eat less, try to eat the right food, and ensure that you do some form of physical activity, including Surya Namaskar, Uthak Baitak, and many other yogic asanas. And be cheerful, smile. Even if you have corona, you have to live with corona. Please be cheerful. Don't live in COVID anxiety. Conquer COVID anxiety. It is important to recognize that what is most important in COVID is the degree and confidence. So smile with COVID, but don't be careless. Be cautious. Be careful. Don't be reckless, but take the right precautions at the right time. And unfortunately, even if you get a COVID infection, most people are going to survive, because recovery is a rule, death is an exception, unless you are unfortunate in the vulnerable population. And if you get it, keep connected, stay connected with your doctor 24/7. Thank you and Jai Hind.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.